Okay, last session before lunch. I thought it was great having Antonia Patella here last night talking about the origins of BL. It seems to be a congenital drug company, which is quite interesting, sort of gone down through the generations, which is fantastic. And also the genesis of a new drug, the etiology of how, in this case, Opicapone came about, because I don't think we always quite realise that, notwithstanding Simon's excellent talk of what's going on beneath the bonnet. Preparations seem to arrive fully formed, and we don't really know the backstory. So I notice there's no question mark on this presentation, Camille. Opicapone, the promise of the theory.
Yes, I could have turned it into a question.
Oh, you put the question up, have you? Oh,
no. Does the theory hold promise?
Oh, excellent.
Better, yeah.
Okay, I'm sure you'll give
us revised title.
A forensic analysis of the topic. Many thanks.
So thank you very much for the invitation to speak. And I'm going to change gears slightly and talk more about the drug, Opicapone, made by the sponsors of this meeting. And I'm also impressed, as Peter is, that it's a family company and interacting, as I'm sure all of you have experience of, interacting with the folk that work for BIAL is always a very pleasurable experience. Their drivers are very much improving patient care, improving patient outcome, improving the lives of people who live with Parkinson's, and of course that's something that resonates with all of us. So these are my disclosures. You can see BIAL actually features quite prominently. So these are my aims. The first aim is to give an introduction. This is going to be duplicating a bit about what you've already heard, but going into a bit more detail about the categorization of Parkinson's subtypes, just to think about where we might start to use drugs for particular patients. And I'm going to talk a little bit about levodopa metabolism. So pharmacology is not my thing, so I'm just going to touch on that. Then there's some interesting theoretical reasons why we might start to consider using Opicapone or COMT inhibitors in a slightly or for slightly different reasons. And I'm just going to talk quite a bit about that. And there's a couple of slides on how to manage adverse effects, dyskinesia, when you start Opicapone. But I sort of feel that's like teaching this audience to suck eggs, so there's only 2 slides on that at the end. But we can discuss that more later if people wish to. So to start with Parkinson's subtypes, as you've heard, this is an increasing area of interest. Not everyone with Parkinson's is the same, we know that. Can we group people into subtypes or types of Parkinson's in order to guide our treatment decisions? If it's not going to make any difference to what we do, then why bother engaging in the activity? But actually this will guide our treatment decisions, either with symptomatic treatments or, as we've heard from Simon and Alistair, possibly our neuroprotective treatments as they start to come along. So it's important we understand what underlies the difference between different types of Parkinson's. And we call that stratification. Stratification is the new thing. The NIHR wants to have stratification champions in all our different specialty groups. This is a word that you will hear more and more of over the coming years. And we can stratify in 2 simple ways, by phenotype or by genotype. So phenotype, what do people look like? Genotype, what's their makeup? And we can think about, if we stratify people by phenotype, how is their disease affecting them? What is their disease looking like? That's guiding our treatment decisions. That's personalized medicine. And if we're guiding our treatments based on their genotype, so with a LRRK2 inhibitor, for example, we might call that precision medicine. And these are other terms that are bandied about with varying definitions, but this is just how I'm choosing to use them. And then the future, of course, is pharmacogenomics. So how can we predict, will we be able to predict who's going to get a particular side effect to a drug, or who's going to be a responder or a non-responder or a super responder? How can we determine whether people will do well or not so well with a particular therapy based on their genetic makeup? Excuse me. So stratification by phenotype, not a new idea in Parkinson's by any stretch of the imagination. So tremor dominant versus postural instability gait disorder, these are 2 subtypes of Parkinson's that we've all grown up with. And this is a nice study from 2006 looking at pathologically post-mortem proven Parkinson's disease and looking back over the history of those people prior to death, and defining 4 subgroups Basically based on their motor features, so tremor dominant, non-tremor dominant, rapid disease progression without dementia. So dementia is the only non-motor symptom mentioned in this categorization here. And this, of course, is a world away from our current understanding of phenotype. So each of these bars is a non-motor symptom, pretty much on the whole. There are bars for tremor and I can't remember what else there is. Tremor, I think maybe rigidity somewhere, laterality, but otherwise these are all non-motor symptoms. Urinary problems, constipation, hallucinations, blood pressure, sleep, smell, cognition, psychology. So these are all part of the phenotype of patients who are presenting with Parkinson's disease. And you can see there are some folk in group 5 here. This side's worse, this side's better. Group 5 have a huge non-motor symptom burden, whereas group 3, they have bad tremor, but actually from everything else point of view, they actually do pretty well. So if we include non-motor symptoms in our stratification, excuse me, we can get much more refined subtypes, and this has come out of the Oxford Discovery project that Parkinson's UK support. And lots of you would have recruited people, if not to that study, then to Proband, Tracking Parkinson's, which I think has 70-odd sites across the UK, led by Donald Brossett. Michelle leads the Discovery cohort, and they've combined their data sets, they've got very similar data sets, to take those previous 5 clusters and refine them down to 4. And this is a nice paper by Michael Lawton representing the team, defining these four clusters. So this is baseline features on which we can now start to predict how people are going to do. So this cluster 1, the fastest progressing cohort of people with a poor levodopa response, very prominent non-motor symptoms and very symmetrical. So this might be the postural instability gait disorder phenotype. And then somewhere, where was it? Cluster 4, tremor dominant, slowest progressing. Again, poor dopa response, because tremor is often dopa resistant, but actually they do pretty well. They've got the slowest progression and then 2 intermediate progressing phenotypes. So we can start to predict how people are going to do based on how they present from both a motor and a non-motor perspective. So that's quite helpful. And we can, sorry, I sort of feel there might be something. Yeah, there is. This is the problem when you pinch slides from other people, isn't it? You don't know what's going to come up on the clicks. This is Michelle's slide. So she has shown that if you look at the cohorts from Tracking Parkinson's and her Discovery cohort, if you look at the progression over, the change in UPDRS 3 points per year in these different clusters, the fastest progressing ones are progressing by about 3 points a year, and the slowest progressing ones progress by less than 1 point a year. So why is that important? She had this slide, as indeed the reason that I copied it, was for trial design. If we've got a clinical trial for a neuroprotective agent where we happen to have biased our randomization in some way so that these are the active group or the placebo group, this sort of difference in our baseline cohort can affect our outcomes. So we need to be alert to this. So if maybe we should be selecting the most rapidly progressive people for neuroprotective trial design and not including these people because there'll be no response. We're not expecting there to be any progression for a drug to act on. But we can use this information clinically, and we do in Plymouth. Plymouth team is well represented here today. So this is dead simple. Really nice tool. You can find it in the supplementary material to this publication in Neurology last year. This is Caroline Williams-Gray's team in Cambridge, and it's an Excel spreadsheet. And what you put in is how old the patient is, how many animals they can name in a minute, and the 4 items of the postural instability bit of the UPDRS takes maybe, 3 minutes to do in a clinic. And these are people newly diagnosed with Parkinson's, and what you get is a prognosis score, a chance that they will have an adverse outcome at 5 years. Adverse outcome being defined as developing falls, developing dementia, or dying. So ignore that guy who was a bit of a strange guy. But on the whole, you can see it's fairly age-dependent. So if you are pushing 90, obviously, there is less chance you're going to live for the next 5 years. Whereas if you're in your 40s, quite a good chance you're going to live for the next 5 years. So there is, age obviously drives it hugely. But interestingly, between the mid-60s and the mid-70s, there's a big spread of patients. So some of these patients are going to do really well, and some not so much. These people are going to develop dementia and falls and have a higher mortality. And at the moment, our service differentiates not at all in terms of provision. So we're starting to tailor our service to think, well, these people, we need to be much more alert to their bone health, early physio, falls prevention, carer support. The chances are that these carers will already be at a higher burden. And remember, this is newly diagnosed Parkinson's. So we can start to think about just the way that we design our services and where we plug our resource into where it might be most needed, just on the basis of a very simple score that we can do in clinic. There are more sophisticated phenotypic markers, and I'm sure that these will be coming along. And I'll talk a bit about these. So systemic inflammation, we know that Parkinson's is associated with microglial and inflammation in the brain. There's also evidence of systemic inflammation that we can pick up. Gait parameters, lots of wearables, and imaging, genetics, and spinal fluid tests. So this is Caroline Williams-Gray and her group in Cambridge who came up with that prognostic indicator. She's very interested in systemic inflammation, and she has shown that people who have a pro-inflammatory serum, so lots of cytokines of an inflammatory nature in serum, are associated with more rapid motor progression over the next 6 months. And if you've got an anti-inflammatory serum, then you're going to have a better prognosis. So again, we can probably measure this quite well. Of course, we can measure it quite readily in clinic, but we don't. So she has started a trial of azathioprine as a neuroprotective agent in people who do have this high inflammatory risk to see whether it might be protective. So that's very interesting. Gait, you'll know Lynn Rochester, whose group in Newcastle has really led the field nationally and internationally for gait analysis and prediction of outcome in Parkinson's disease. And they've published, a load of work. So I've just pulled out a couple. One is that you can use gait parameters, so things like stride length variability and postural sway, stride length, those sorts of things, to predict first fall in newly diagnosed. And we're not that far away from using these sorts of wearables in clinic routinely for gait analysis, whether it's a shoe insole or whether it's a lumbar 5 sensor or whether it's a whole pack of sensors that you wear attached to hips and trunk. Who knows what it will be? But within the next, there are loads of companies that are contacting us all the time to use their bits of kit to predict first fall. So I can imagine this will be something that we'll be using clinically. Interestingly, if you look at the gait parameters and people's cognition, it's the gait parameters that predict dementia onset more than their baseline cognition. And we know from work that Alan has done with Emily Henderson that the two symptoms, cognition and gait impairment, are probably both cholinergically mediated. And you'll be aware of the Emily's trial for rivastigmine, a cognitive drug being used to prevent falls in Parkinson's disease. And then there's all this other fancy stuff that we can't do in Plymouth, so not so interested in that. But you can look at quantitative DAT scans in our centre. They will sometimes do it quantitatively, but they're still basically doing a qualitative assessment, eyeballing it. Does it look normal or not normal? But you can look at it in a quantitative fashion and get increased sensitivity out of your DAT scan. You can look at MRI features. We don't have a 3T MRI scanner in Devon yet. You can look at CSF proteins, and you can look at genotype, things like COMT and BDNF. And all of these things predict cognitive impairment, rate of progression, how well you're going to do. But this isn't, this is a world away from our little 3-minute clinic test. So this may be coming, but it's not quite so practical to deliver. And we've heard about stratification by genotype, and these are the two most common, LRRK2 and GBA mutations, and you've heard already from Simon and from Alistair about the treatments. So LRRK2 kinase inhibitors are coming. LRRK2 antisense oligonucleotide is a trial which is going to be opening within the next year. GBA, the Ambroxol study, has finished. The Sanofi study is still recruiting. So these are trials targeting people by their genotype. Probably the only examples of stratified trials thus far. And of course, Alistair's talks us through very elegantly about this prodromal phase, but what will be interesting will be whether you can identify some of these subtypes, disease subtypes, post-manifestation in the prodromal phase. Are there prodromal subtypes? So at the moment, we're still struggling with identification of prodromal Parkinson's per se, but if we think that neuroprotective therapies are going to be targeted to particular subtypes, other than by genotype, how can we identify those subtypes? So I'm sure there'll be lots of data from studies like PREDICT-PD that will help that. This is another platform that aims to look at those subtypes in more detail. This is Rhapsody. It's looking at GBA mutation carriers and pre-manifest Parkinson's and the sorts of things that might predict onset and disease progression, and the PREDICT-PD website that Alistair's already highlighted. And then the other thing that I want to say about genotype was we know already, Alistair said, that GBA mutations are more likely to be associated with a worse cognitive outcome. And we know from Roger Barker that the COMT, that one can't really see it, that the COMT genotype is likely to affects dopamine metabolism, of course, and we know that dopamine is important for frontal executive problems. We also know that tau mutations and ApoE mutations, because they drive Alzheimer's type pathology, also affect cognitive outcomes. So we can tell, even from these 4 genes, how people might do in terms of either frontal dysfunction or dementia, posterior-parietal type dysfunction. But there's a whole raft of other genes where there is some evidence that people will do slightly differently, either with regard to their Parkinson's or in response to various treatments. So this is Ray's slide. So impulse control disorders associated with polymorphisms at the D3 dopamine receptor, for example, sudden onset sleep, the D4 dopamine receptor. So maybe these are people that in the future, if we start to get this information, these might be people that we're more cautious about putting on a dopamine agonist. So the information might be there, but we just don't use it clinically. So what's possible in terms of subtyping is actually quite sophisticated and might drive our pharmacogenomic type decisions. And what this is leading to, of course, is personalized medicine, which is another huge area of focus. This, I think, is a US-based organization wanting medicine to be predictive, preventive, personalized, and participatory, critically patient-centered, and to involve the patient and their experience of their lived experience of their disease in one's decision-making about how it's treated. This is another one of Ray's slides. So if you go back to what I was saying about before, if you have this idea of personalized medicine and thinking about subtypes, if it's a genomic subtype, you can be very precise about your intervention. You might even in the future, with PREDICT-PD and Rhapsody and those sorts of platforms, identify people and have a precise genomic intervention which is preventative. That would be great. And then for people that don't have those genotypes, you can tailor your medicine to the needs of the patient, be it symptom-specific or subtype-specific. And the whole of personalized medicine involves all of these things. So what the biomarkers are telling us, what their comorbidities are, a bit about their clinical subtypes, whether they're high risk, low risk, managing all their motor and non-motor features, but not forgetting the importance of lifestyle, the patient's personality and preferences, which will determine at what point they engage with us in their decision-making process already, and Alistair's alluded to that too. So that's all I was going to say about subtypes. So moving on to levodopa metabolism. Levodopa is absorbed when people ingest it, and then it is actively transported across the blood-brain barrier, gets into the brain, and it's broken down by dopa decarboxylase into dopamine. Unfortunately, this also happens in the periphery, as we heard about from, was it Oliver Sacks yesterday evening? I can't remember, maybe Oliver Sacks. Yeah, so what we need to do, if it is broken down into dopamine in the periphery, this causes dopaminergic side effects in the periphery, makes us feel sick, makes us feel dizzy, not so good, and dopamine does not cross the blood-brain barrier, so that is doing nothing to help our Parkinson's. If we inhibit that with carbidopa or bensericide, then obviously more levodopa is available to get into the brain, good thing, but what we mustn't forget is that there's this other enzyme, COMT, which breaks L-dopa down into 3-OMD, which means that less is then available to get into the brain. This may compete for transport across the blood-brain barrier, so I was sort of interested in that, because I thought, oh, well, maybe this is a reason why people become less responsive to levodopa. This apparently has got a large volume of distribution, it hangs around for ages, it isn't broken down so readily, but folk were thinking about this in the late 1980s. Actually, Nutt did a bit of work on this, and they did the pharmacokinetics and measured the levels of the various metabolites and were not able to show that one's levodopa response in any way related to what the 3-OMD levels were. So although this is theoretical, I don't know to what extent that actually is clinically relevant. However, we now have drugs, of course, that can block COMT activity, which means that more levodopa is available to get into the brain. The dopamine, once in the brain, is broken down by MAOB, and of course we can inhibit that with the MAOB inhibitors, which means that dopamine hangs around longer. So all of these medications essentially allow you to get more mileage out of every bit of levodopa that's absorbed. L-dopa is also broken down in the brain by COMT, and you will know that tolcapone is the only one of the COMT inhibitors that actually has efficacy in the brain. The other two, entacapone and opicapone, are purely peripheral. So I wasn't around, Peter, when tolcapone, not as a functioning neurologist, just as a baby neurologist when tolcapone first came onto the market, but I inherited quite a lot of Doug McMahon's patients from his Liscard clinic, who were on tolcapone, and I understand it was a real wow moment in Parkinson's therapy, which of course has diminished since. I still do have some of Doug's patients still on it, but I've not ever initiated it myself. So what this means, sorry, this is a blurred picture, is that if you just take a levodopa tablet on its own, like mercunapurians, so Baz told us about this yesterday, take your mercunapurians, you've got levodopa in the system, and you don't block any of these enzymes, a lot of it is broken down by dopa decarboxylase, and only 1% of it will actually get into the brain. If you add dopa decarboxylase, you increase that to about 10%. So that's good, and that is our standard therapy, of course. 10% of whatever people take get into the brain. If you block COMT, that goes up to 75%. So actually, that's quite a significant increase in the bang for your buck for that levodopa tablet, which may or may not, have got stuck in the esophagus on the way down, or be still in the pharyngeal pouch, or be stuck with the gastric emptying. So these are all the things that we need to think about to get more mileage out of every bit of levodopa that actually gets to the right place to be absorbed in the first place. So if we're going to inhibit COMT, what's the best way to do it? And we've got two sort of day-to-day options. One is entacapone, one is levodopa. one is opicapone. And this graph just nicely illustrates, as you know, that the COMT activity is inhibited by both entacapone and opicapone, but the entacapone you have to take with every levodopa dose because its activity is so short-lived, whereas the opicapone you get much more effective inhibition of COMT with one dose which is sustained. So the chances are that you're going to get better efficacy from that. And you can look at that as sort of a proof of concept with target engagement is the 3-OMD levels. So if COMT is active, you get a higher rise in 3-OMD because that's what levodopa is being metabolized into. And if you block it, your 3-OMD levels fall. So if you give somebody placebo and then levodopa, of course their 3-OMD levels go up because their levodopa is being converted into this. And you can reduce that by adding entacapone, and you can reduce that further still by adding, giving them opicapone. So opicapone does seem to be a better inhibitor of COMT, and you'll know this data from the clinical trials that showed that this does in fact translate into better clinical efficacy for patients. So this is change in off time. When patients change from entacapone to opicapone, they get an even greater reduction in their off time. So that seems to show that opicapone does what it says it does. So the next bit of the talk is about where might this be useful in bits of Parkinson's that we don't often think about. So the two bits that I'm going to talk about particularly are vascular disease and peripheral neuropathy, and vascular disease and cognitive decline are, of course, very much interlinked. And this is the issue. The issue is homocysteine. Now, I said that pharmacology wasn't my thing, neither is biochemistry, so I'm going to try and keep this simple. It will be simple. So this is homocysteine, and homocysteine is made by COMT. Methylating, metabolizing methionine through this pathway, and COMT activity driven by levodopa actually will drive this pathway and push up homocysteine. So when you take in a metabolite such as levodopa, that will stimulate the pathway and activate it, resulting in increase of these downstream products. Homocysteine can be converted back to methionine using these vitamins, folate and B12. And it's also converted into cystathionine using another vitamin, vitamin B6. So the upshot of that is that if you have low folate, low B12 or low B6, you aren't able to get rid of homocysteine so well, and so your homocysteine levels will go up. Whereas if you're driving the production of homocysteine by adding levodopa, your homocysteine level will go up. And if this enzyme COMT is very active, your homocysteine level will go up. This enzyme here, I think the R stands for reductase, I'm guessing the M stands for methylene, but I actually can't remember what the other letters stand for. This enzyme here, there's a genetic polymorphism that will drive homocysteine, which will increase homocysteine levels. And it might be that one's genetic makeup here actually determines what our homocysteine levels are. And I'm guessing that will probably be true for all the other enzymes involved in these pathways. So homocysteine levels are increased by low folate, low B12, low B6, increased COMT activity, and we know they're also affected by this particular genotype. And we know that homocysteine is increased in Parkinson's disease. So why does that matter? Well, we know that homocystinuria, is one of the causes of young person's stroke. It's one of the things we screen for if people present early with vascular disease in an unexpected way. It's a risk factor for vascular disease. We also know it's a risk factor for dementia. And there have been a couple of meta-analyses of these things. One found that for every 5 micromole per litre increase in homocysteine, there was a 42% increase in heart disease and a 65% increase in stroke risk. The converse has also been shown that if you reduce the homocysteine, you reduce the risk. So that implies a causative rather than an associative interaction. So for every reduction of 3 micromoles per litre, you reduce your risk of cardiac disease or stroke by 11%. So homocysteine is not a good thing to have circulating at high levels. Why is that? Ron Postuma and Tony Lang wrote a really nice paper back in 2004 in Neurology about this and postulated why homocysteine might not be a good thing. So it results in free radical formation, lipid oxidation, inflammation induction, endothelium damage, procoagulant state we've talked about with the stroke risk. All of these things, excitotoxicity, impaired DNA repair might lead to dementia, and because it might result in worsening inflammation and also affects the activity of complex 1 in the mitochondria, it might actually worsen Parkinson's disease. So this paper, 15 years ago. And as I mentioned, there's this genetic influence. So there's heterozygosity at this particular allele with a frequency of 35%, and it's the TT homozygous state, which is the unfavorable one. Up to 12% of people are TT homozygotes, and they can have dramatically high levels of homocysteine, particularly if they've got some B12 depletion as well. And we know that people who are TT homozygotes at this allele do have increased vascular risk. And there are some reports, although not repeated, but there were some reports that if you are homozygous TT at this gene, that might predispose you to developing Parkinson's disease. I'm guessing because of this increase in homocysteine and the potential mechanisms by which homocysteine might affect. So what about the evidence for homocysteine in Parkinson's disease? In this particular study, what they did was they measured homocysteine levels before and after starting levodopa. 20 patients, and after an average of 110 days, the homocysteine levels had increased, almost doubled, from 10 to 18. And they realized that the Parkinson's patients that had the highest levels, so the highest quartiles of increased serum homocysteine, also had an increased risk of vascular disease, which is what we'd expect. And they also noticed, because they genotyped the patients, that those that did have the TT genotype at the 677 allele, the rise in homocysteine was much greater in those people than in the people who were CC or other CT heterozygotes. So that suggests that it isn't Parkinson's disease per se that increases one's homocysteine. It's the fact you've given them levodopa, and that's what's driving that metabolic pathway. And this is sort of substantiated by a meta-analysis a few years ago now. This is baseline Parkinson's not treated, and you can see that diamond crosses 0. So although some of these studies did suggest that Parkinson's disease, this particular one in particular, is associated with a higher homocysteine level just in and of itself, which might be related to the polymorphism that I talked about. Overall, there isn't an increased level of homocysteine just with having Parkinson's disease. However, once people are treated with levodopa, there absolutely is a rise in homocysteine level with increased vascular risk. Is that increased vascular risk also true in Parkinson's disease? Is the homocysteine managed differently from the general population? Well, there are studies that show no, that is not the case, and it is absolutely a risk for vascular disease as well. So these are people with Parkinson's now looking at particular vascular parameter, and it's vascular dilatation, which is a measure of vessel stiffness, and having stiff vessels is not a good thing. You want nice, pliable blood vessels. And the people who were on levodopa had less dilatation, so stiffer blood vessels than controls. And you can see that in this particular study, they blocked COMT with Opicapone and showed that they were able to significantly improve that vascular effect of homocysteine. And this is just looking at it in a different way. So the homocysteine level, the people that had the highest homocysteine level also were in the highest tertile for vascular stiffness. So there seemed to be a direct correlation, and you could improve that by blocking COMT with Opicapone. There have been other studies looking particularly at what homocysteine does in Parkinson's disease, and this study, again 15 years ago now, showed that for people that had a high homocysteine, they were more likely to have worse mood and, not surprisingly, worse cognition. And in this study, they were looking at sort of this interaction between B12 and homocysteine because the pathways are related. And the only result here that's got a star next to it, as in being significant, is this one. So they looked at baseline B12, baseline other metabolites of B12, and baseline homocysteine, people that had levels greater than 15 micromoles per litre versus lower levels of below 15 micromoles per litre. And then they looked at how things changed over time. And they found that people who had a high baseline homocysteine had significantly greater reduction per year in their MMSE scores than people who had lower homocysteine. So this suggests that if you have high homocysteine, your cognition is going to decline more rapidly than if you have lower homocysteine. And that might be related to those vascular effects or other effects of the free radical effects, the excitotoxicity, whatever it is that homocysteine is doing. And this has been reviewed more systematically. This is from a couple of years ago now. They reviewed 15 papers. And again, the evidence is very much along the lines that I've said already, that people with Parkinson's who have cognitive dysfunction were much more likely to have higher homocysteine levels, lower folate, low B12. And they did find that people with Parkinson's compared with controls were much more likely to have a high homocysteine level, which is probably driven by the levodopa treatment that we're giving folk. This has been repeated in a UK population. This is David Burns' ICICLE cohort, looking at the effect of urate, which we've heard about, and also homocysteine on both motor progression and cognitive progression. And you can see, as Alistair illustrated, this confirmed those findings, that if you have a low urate, you have worse motor progression. Also, if you have high homocysteine, you have worse motor progression, but it is only the homocysteine that is correlated with a worse cognitive progression. Urate does not seem to affect cognitive progression, just motor, which is interesting. So in summary, homocysteine levels are elevated in Parkinson's disease, might be elevated at baseline if you've got a genetic predisposition, but almost certainly elevated in relation to giving people levodopa because we're activating COMT, and that is driving homocysteine production. And if you have high homocysteine, you're at higher risk of vascular events anyway in the general population, and if you happen to have Parkinson's disease, that high homocysteine will be driving a worse motor outcome and a worse cognitive outcome. So how about reducing the homocysteine? What is the evidence that reducing homocysteine might be a good thing? So again, Ron Postuma and Tony Lang, after they'd written their piece in 2004, they went on and did a trial, double-blind RCT, 1 milligram of folate or 500 micrograms, combined with 500 micrograms of B12 or entacapone or placebo for 6 weeks. And they measured various bits and bobs, and this was their homocysteine level. So they could show that from a baseline of this is relative, from baseline state of homocysteine, they increased homocysteine levels increased after levodopa initiation. And the thing that I found sort of interesting in this, although it was 2006, was that at 6 weeks they were already on 450 milligrams of levodopa a day. I thought that's a bit sporting. So I thought that was interesting. However, they also looked at the effect of their interventions on that change in homocysteine. So placebo made no difference. Entacapone, interestingly, made no difference. But the vitamin combination, folate 1 milligram a day, 500 micrograms of B12, reduced the homocysteine levels quite significantly. And they talked about why entacapone might have made no difference, and they talked about confounders. So around this time, flour was being fortified with folate in the States. And they talked about other sort of dietary confounders that might have affected their study. However, they were able to show that vitamin supplements reduce reduce homocysteine levels. They're not the only group to have done this. So Lamberti, around the same time, just published a year later, he did the same thing. So he had, looked particularly at Entacapone on homocysteine levels. So group A was treated with levodopa, group B, levodopa and compt, and then the control group. And what he found was that homocysteine levels here were much higher in the levodopa-treated group than the control group, and also found that he could a significant reduction in those homocysteine levels with Entacapone. So that suggests that Entacapone might be effective. And this has now been subject to a meta-analysis, and this confirms, you can see there's only three studies, but it does confirm those findings that overall Entacapone seems to reduce homocysteine levels in Parkinson's disease. And then I found this paper, which I thought was really interesting, because it's where we're all at, exercise. That exercise reduces homocysteine levels in Parkinson's disease. So this was the overall group of patients, homocysteine levels in those who didn't exercise, homocysteine levels in those that did, significantly reduced by exercise. And then they wondered whether there might be a dose response to the levodopa, whether it's a dose response thing, the higher your dopa dose, the higher your homocysteine rise. And interestingly, there was a dose response, but only in the non-exercisers. So it seemed that the amount of levodopa that you were giving people, driving up their homocysteine, but only if they are not people who exercise. And the exercise was 3 hours a week for 6 months. Supervised, they had to come to a gym, and it was moderate intensity. It wasn't, it didn't sound too grueling. So I thought that was really interesting. And then another interesting study that I found was the use of rivastigmine in people who've got high homocysteine as a cognitive enhancer. So looking at changes in ADAS-Cog, which is a cognitive measure, and as you might expect, so this black circles here is people who've got high homocysteine and their ADAS-Cog scores decline with time. So at week 24, they're not as good as they were before. If you give them rivastigmine, that improves their cognition quite significantly if they've got high homocysteine levels. The people with normal homocysteine levels who are given placebo, so that's the white circles, they improve with time, which I guess you would say would be either a placebo effect or a practice effect. They also get better with the rivastigmine. And initially I thought, well, rivastigmine hasn't really made any difference. You know, whether you had high homocysteine or low homocysteine, you end up in the same place. But what the authors wanted to demonstrate was because the high homocysteine people would have done so much worse, because they would have declined, whereas everyone else over 24 weeks is pretty much stable, the gain that you get with in people with high homocysteine, the gain that you get with adding in rivastigmine is proportionately much, much bigger than the gain that you get for people who've got normal homocysteine. And I just wondered whether this reflects some of what we see in practice, that we put some people on rivastigmine, maybe it does a bit, maybe it's not doing much, and you put other people on rivastigmine, and they seem dramatically better. And I wonder whether it's because they would have been there otherwise, but they're the people with the high homocysteine, which of course we don't normally measure. So in summary, homocysteine levels can be reduced. The meta-analysis has shown this by COMT inhibitors, definitely by vitamin supplementation, possibly exercise, and of course Opicapone, being new to the party, hasn't really been tested in this sphere. So the next thing I want to talk about is peripheral neuropathy, which is a linked theme. I can't actually see the time. How am I doing for time? 5 minutes, okay. So we know that peripheral neuropathy, of course, adds to risk of falls, immobility, it's also pain, with small fibre neuropathy. It's also linked to autonomic dysfunction. It often begins subclinically, so patients might not be aware they've got peripheral neuropathy. We're not aware they've got peripheral neuropathy. Sometimes if it's a large fibre neuropathy, you might only pick it up by nerve conduction studies, and if it's a small fibre neuropathy, you won't even pick it up by the nerve conduction studies. The diagnostic test is a skin biopsy, but they might have reduced temperature sensation or reduced pinprick sensation. And it's very common, actually. So in patients who had, this is looking at the incidence of it in people who had long-term, which in this study they defined as more than 3 years levodopa exposure versus less than 3 years levodopa exposure versus no levodopa exposure. So this would be dopamine agonists and rasagiline and things like that. And you can see that the prevalence percentage-wise of peripheral neuropathy in people with Parkinson's, if they didn't have any levodopa exposure, was 4.8%, which is about what the general population, the elderly general population would have. But in people who've got more than 3 years of levodopa exposure, that goes up to 20%. So that's not insignificant when you think about contributors to falls risk and contributors to immobility. It's a bit like the BPPV that Baz was telling us about yesterday as contributing to falls and dizziness, which we don't look for, but it might be there at 10 or 20% of people. And we know from a systematic review of people with peripheral neuropathy and Parkinson's disease that on the whole, the prevalence is probably about 30%. On people taking oral levodopa, 30% will have a peripheral neuropathy, which is chronic, creeps up on one, therefore unnoticed. The reason this has come to our attention, of course, is because of duodopa and the intestinal gel, where 40% would have a peripheral neuropathy, but it's subacute or acute. It happens quickly, people notice the difference, and that's why they report it. And we know that the peripheral neuropathy, again, increased homocysteine, and also very much the B12 metabolites. So you get, if B12 is depleted, you get increase of MMA here in the B12 pathway, and you can measure that. So reduced B12, reduced B6, increased homocysteine, because these pathways aren't working, so this goes up, that goes up, and we know that that's associated with a neuropathy. And we know that if you treat the neuropathy with B12 replacement in Parkinson's disease, which is this group here, if you give B12 replacement, this bit says worsening motor weakness on exam. None of those got worse, whereas other neuropathy patients continued to progress. 23% would continue to progress. These aren't Parkinson's patients, these are just peripheral neuropathy patients who don't have Parkinson's disease. So vitamin supplementation in Parkinson's disease with levodopa-associated peripheral neuropathy will be of benefit. Stabilize the neuropathy and normalize the homocysteine and MMA levels. So it does suggest that these things are causative, not just an association. So peripheral neuropathy, common in Parkinson's, associated with levodopa exposure. We can predict it, sort of, by measuring homocysteine and MMA. These people will be at risk of peripheral neuropathy. We need to be aware that the most common cause of B12, B6, and folate depletion is dietary. And these folk will be losing weight, they'll have poor dietary intake, and we may or may not remember to refer them to a dietitian, but we absolutely need to be alert to their B12, their B vitamin complex intake, so that we're not exacerbating that, and think about vitamin replacement. So this is why I wonder whether all of that theory holds a promise. If we go back to this slide that shows actually Opicapone is even better than Entacapone at preventing 3-OMD and therefore homocysteine accumulation, maybe there's some promise for the drug in ways that we hadn't thought about before. And maybe we can start to think about where we might use this in our clinical practice, in our subtypes. If we know that someone's at high cardiovascular risk, if we've done our prognostic score, if we know they're going to fall, should we be checking them for homocysteine, MMA, B12 levels? Should we be checking for an occult peripheral neuropathy as well as their BPPV? We know that they're going to have a high risk of dementia. We absolutely should be ensuring that their homocysteine levels are brought down into a normal range, and whether we do that with B vitamins or whether we consider the use of COMT inhibitors is something that we need to think about. Not my slide. So I'm just going to end with one slide, or maybe two, on I'm going to skip over that one, on how to mitigate adverse events in people that you start Opicapone on. And as we've heard about already, the key thing is managing expectations. We know that this drug puts up levodopa levels, and we know what the side effects of levodopa are. So we can explain to our patients, we are expecting you to get worse dyskinesia. That tells us the drug is working. That is a good thing. So don't abandon the drug. Let's put in a place to mitigate these side effects that we think you may have. If someone's already starting to have hallucinations, this might make them worse. But if it stops them being off for 2 hours in the afternoon, that is a good thing. Let's manage those hallucinations in a different way. That may or may not require a nurse phone call within the next 2 weeks. And of course, services may struggle to provide that early follow-up. But as long as you get a clear plan with the patient and the carer, I think you can encourage people to stay on the drug because we know it works. And I would encourage people to stay on it for at least a week anyway before you decide what to do about that dyskinesia, because often it settles after a few days and people reach a new norm. And as I say, the key for people who might struggle with anxiety around that is early contact. But the worst thing is when you get the letter back 2 months later from the GP that says, oh yes, the Opicapone worked for their off periods, or it might not even say that, just the Opicapone caused worse dyskinesia, so we stopped it. And then you've lost that opportunity for therapeutic intervention for something that could have been managed by better managing expectations. So that's all I want to end. Thank you very much.